I've got the pleasure of introducing two gentlemen with whom I worked for a number of years, and they're going to be talking about patient-reported outcomes and how to incorporate those into your commercial strategy. There's been a lot of talk around patient-reported outcomes, FDA guidelines. You've heard some of the previous speakers touch upon patient-reported outcomes. The fact is they're taking on new importance, and regardless of what guidelines say or don't say, at the end of the day, you can't develop real-world data without patient-reported outcomes. So it's very important to incorporate those into your development strategy and your commercial strategies. Again, you've heard this over and over, very early in development. So I'm pleased to introduce Nathan White, who is the Executive Director of Reimbursement and Market Access at Inventive Health. Nathan has a specialty pharmacy background. He used to be at Express Scripts and CuraScript, and he worked with me at ParXL for a number of years, working to develop good, workable, tactical solutions to make sure that patients get good access to therapy. And then he is going to be assisted by Steve Bloom, who is with eyeforpharma Oncology. Steve is the Vice President of Business Development at eyeforpharma. He's been there for 4 years, and prior to that, he was at ParXL with us as well. So it's like old home week here, and I'm now going to introduce Nathan to you. Nathan.
Good afternoon. Welcome back from lunch. I hope that everyone is managing to stay well caffeinated this afternoon. The good news is that we're almost to cocktails, so stick with us for the next 35 minutes or so. I promise not to intentionally put you to sleep. I think our program today has been excellent. Certainly a lot of focus on demonstrating value in the oncology market. My name is Nathan White. As Chuck said, I'm Executive Director for Access and Reimbursement at Inventive Patient Access Solutions. Patient Access Solutions is a premier provider of patient access and support program design and operation, helping more than 1 million patients each year get access to free drug and reimbursement support. Today, Inventive Health's 13,000 team members serve over 400 clients through our 3 core business units. Our clinical segment, PharmaNet i3, is one of the largest global contract research organizations with a full suite of product development solutions. Inventive Health's consulting segment, Campbell Alliance, is the nation's premier management consulting firm specializing in biotech and pharmaceutical. And Inventive Health Commercial is a collection of businesses focused on healthcare advertising and PR, selling solutions, patient access, and outcomes. So if I had the ability to play the Star Wars theme song for you right now, I think it would help even more drive home this statement taken from a recent article on market access by Dr. Luzheng Wang, who heads up the pricing and market access practice at Campbell Alliance. He says, if the pharmaceutical industry's premier and principal challenge of the last 10 years has been reinventing the R&D model to address productivity, the next 10 years could very likely be termed the rise of the payer. As the pharmaceutical industry prepares to embark on what will be one of the most challenging decades in U.S. healthcare history, I want to note some important questions. How will healthcare reform shape the future of the industry? How will we attack the challenge of proving value to payers? And how will we overcome constant changes within our regulatory agencies? And ultimately, what does this perfect storm look like, and how do we prepare to successfully weather it? Last May, Bill Martin with Accredo Health gave a great keynote address at the Armada Specialty Pharmacy Summit in Las Vegas. And if those of you who work in the specialty segment haven't been to the Armada Summit, and I promise I didn't get paid to plug this, it's a great networking and learning opportunity. In Bill's keynote address, he outlined several key industry trends that I thought I'd take a moment to share with you today. Obviously, we're all quite aware of the growing specialty market opportunity, with 80% of the world's top-selling drugs falling into the specialty category by 2016. We've already heard discussion about personalized medicine and the trend towards integration of biomarkers into clinical studies. And the pipeline for specialty is substantial, and even more so in oncology, with over 40% of drugs in the pipeline focusing in this therapeutic area. And I'll share some key learnings from a Campbell Alliance Oncology National Commercialization Study in just a few moments. I won't take time to go into the Affordable Care Act, since I believe it's been covered pretty well so far, but implementation is underway, for better or worse, I guess depending on which side of the ballot sheet that you tend to mark. The Supreme Court is likely to hear arguments on key components, including the national coverage mandate starting next month, which I'm sure will keep many of us glued to our smartphones. Interestingly, I heard on an NPR program last week that the Supreme Court usually grants about an hour for arguments, and in the case of the hearing on the Affordable Care Act, they've allotted about 5 hours, so clearly it's of a major importance to the court. The federal government has already worked to restrict patient access to copay cards for participants of federal plans, and less than a month ago, CVS Caremark released a blacklist of drugs that it will not cover on its national formulary in 2012. Over 50% of the drugs on that list have associated copay card programs, and the Pharmaceutical Care Management Association, or PCMA, sponsored a report on the negative impact of copay card programs on the managed care industry, and essentially blasted the industry for this tactic. So I'd suggest that you keep the copay card controversy pretty close to your vest, as I believe it will become even more hotly disputed in the coming months. And last, but certainly not least, is the concept of value. Certainly this has been a central theme of the day, so I won't spend a ton of time on that right now. So what are the three key areas we need to think about when launching an oncology asset? Value, specifically clinical and cost effectiveness, patient access to therapy, and data to support our value proposition to payers. So for the remainder of the presentation and for my discussion with Steve, we'll really focus on primarily the data component, specifically around patient-reported outcomes. I think you'll be interested in a survey of medical and pharmacy directors that I just completed that'll shed a little bit of light on current and future perspectives on patient-reported outcomes. I wanted to share some trends from the Oncology Landmark study that Campbell Alliance released last year. In this 18-month study, Campbell Alliance interviewed industry leaders at oncology-focused biotech and pharma, including the top 20, as well as key opinion leaders, regional and national payers, and regional oncology practice stakeholders. They also conducted a pipeline analysis of the past 10 years and leveraged insights from over 300 oncology projects in the last 3 years. The results yielded 10 trends that I found to be quite compelling, and while the report is oncology specific, there are definitely correlations to the general specialty market. And this report is definitely free of charge, so please feel free to stop me at the break later on if you'd like instructions on how to get a hold of it. The oncology pipeline has grown and become targeted towards traditional targets in ever smaller patient populations, further narrowed by biomarkers. And one can see how this leads, as almost by design, to increasing competition. It's tempting to think that this competition is farther down the road and something to worry about tomorrow, but I think this would be a mistake, however, because competition is already seen in clinical trials. Competition for patients, for the best investigators, competition for clinical trial sites. Competition also makes clinical trials longer and riskier. First, the control arm. The control arms are simply better than they used to be, so trials are required to run farther out to determine separation. And I think this is a big issue because trials have been designed assuming a lower efficacy from the control arm, so trials may not be properly powered. Second, acceptance of progression-free survival, PFS, as a primary endpoint may be nearing an end. If the FDA suddenly finds overall survival the only acceptable endpoint, at a minimum, trials will become longer. Trials designed with PFS endpoints may have to be conducted again with overall survival endpoints. The implication of this competition is that flawless commercialization efforts will become vital in order to succeed in a Me Too, Me 3, or Me the 20th VEGF inhibitor market. These trends begin with structural changes in the oncology pipeline that lead directly to intense competition. At the same time, changes in underlying oncology economics have prompted an ongoing change in the most effective oncology commercialization strategies. The days of if you build it, they will come are really coming to an end, if not already over. Competition is precisely the environment where companies need to be able to demonstrate in order to differentiate. However, at the same moment, customers and their needs are changing. This means outdated strategies are not matched to today's commercial realities. So we're at an inflection point. Going forward, winning oncology companies will need to recognize the new reality and organize their portfolios, their launch planning, and customer-facing resources to meet this new reality head on. I've also identified some key trends in oncology market access that I wanted to point out, and helped by my colleague Brett Glass at Campbell Alliance. As payers continue to evolve from traditional hands-off approach to more management of oncology, several tools are being deployed against providers and patients to rein in costs, increase predictability, and improve quality. These tools include decreasing drug reimbursement rates, increasing administrative reimbursement, capitation or episode of care payment systems, forced use of specialty pharmacy, prior authorizations, and clinical pathways. We talked certainly about clinical pathways a great deal already today. Patients certainly will be sharing more of the cost burden through shift of oncology products to specialty tiers with co-insurance and higher cost sharing under the medical benefit. Clinical pathways have become an increasingly popular tool to increase the management and standardization of cancer care. And as reimbursement and other oncology economic pressures build on oncologists, they are increasingly viewing clinical pathways as a potential tool in increasing profitability. Payers are attracted to the use of clinical pathways and appreciate the potential to increase the predictability of cancer spending, to decrease cancer costs, and to increase quality. As payers seek to increase management of oncology, they are increasingly turning towards third-party organizations such as pathway developers. As you heard earlier from Rachel's presentation, for example, Aetna is working with clinical pathway developer P4 Healthcare to develop and implement clinical pathways in Florida and Maryland, as well as 2 additional states to be determined. P4 Healthcare and Aetna will establish regional committees in Florida and Maryland comprised of local oncologists who participate in Aetna's networks. The committees will identify evidence-based treatment regimens or clinical pathways for delivering patient care, initially for breast, lung, and colon cancers. And over the past 3 years, there have been significant changes in the community oncology landscape with a large number of mergers and acquisitions, particularly with hospitals acquiring a large number of practices. The Community Oncology Alliance has been tracking acquisition and mergers of community oncology practices over the past 3.5 years, and some interesting statistics. The organization has noted that there have been more than 300 practices acquired by hospitals, over 100 mergers and acquisitions, and about 200 closures of individual sites. In addition, the standard stakeholders within the oncology landscape the past several years have shown an increasing influence of other stakeholders on access decisions, particularly NCCN, state societies, and third-party pathway developers, as Chuck talked about earlier today. It's also becoming increasingly difficult to determine appropriate price to reflect innovation and return value to shareholders, while at the same time optimizing patient access. And lastly, as payers continue to increase management of oncology agents and other stakeholders become more involved in the decision-making process, it'll become increasingly important to develop the appropriate evidence packages and engagement strategies for communicating a product's value proposition. So that brings us to the question, who cares about value? In order for us to better understand exactly what is value, more importantly, I think we should think about how to demonstrate value. So let's take just for a moment a look at this definition of evidence-based medicine from a respected EBM textbook. Darshan from Novartis Oncology also mentioned this definition earlier this morning. The conscientious, explicit, and judicious use of current evidence in making decisions about the care of individual patients. The practice of evidence-based medicine means integrating individual clinical expertise with the best available external clinical evidence from systematic research. But before we discuss the concept of value and evidence data, let's think a little bigger picture of the concept of market access. As we think about market access in the biotechnology and medical device world, we're faced with complex terminology such as reimbursement, coverage, payment, coding, comparative effectiveness research, health economics, outcomes research, cost effectiveness, and the list goes on and on. But today, many of these terms, I feel, are really misused or used in improper context. So in 2010, a colleague at Parexel Consulting and I attempted to understand how these terms were being used outside of our little market access world, specifically how they were being used in clinical and core clinical journals. and what the prevalence of use was. The results were presented in a poster at the International Society for Medical Publication Professionals. So we quantified the appearance of these terms from year to year in order to demonstrate the rising importance of these concepts within the clinical communities. The term comparative effectiveness research has definitely been on the rise for the past few years, and as you can see here, we saw about a 100% increase from 2008 to 2009 in the usage of this term. The terms comparative effectiveness research and reimbursement saw a tremendous increase from 2006 to 2009. And I think the takeaway from this project was that comparative effectiveness research and reimbursement are definitely becoming more front of mind in the clinical community for probably the first time ever. So let's focus for the next few minutes on the patient. The patient is the most important player in this entire paradigm and probably the most often ignored or forgotten. The area of patient-reported outcomes, as we said earlier, has received a lot of attention as of late, specifically of its important role in CER studies. The patient can teach us, if executed in a thoughtful and science-based manner, many things that we can't learn from the confines of the artificial environment of an RCT. So these self-reports by a patient are often in the form of questionnaires administered by the patient or by a healthcare professional, sometimes over the web or via phone, and in some cases in person. Some questionnaires are disease-specific, while others help to assess the overall general state of the patient's health, which can be used in conjunction with analysis of pharmacy and claims data to create a holistic picture of the comparative quality of health to the economic burden to a patient and a payer. Ultimately, PRO attempts to assess impairments to a patient's health and well-being, as well as the overall quality of life. And I wanted to point out a few instruments that are currently available, with most of these instruments being disease-specific today. The most widely used general PRO instruments are the SF36 and the EQ5D. There are a couple of federally funded initiatives in PRO that I wanted to mention. You may have heard of the DECIDE Network, which is an ARC-sponsored group of principal investigators who are looking at outcomes, effectiveness, safety, and usefulness of medical treatments. Additionally, the NIH-funded PROMISE initiative is developing new PRO tools and will certainly be an entity to watch for new and exciting research in the PRO space. So the meat of my presentation today is to really share with you results of a payer survey we just completed a few weeks ago. We rolled out this survey to 23 medical and pharmacy directors representing over 140 million lives within the US from a myriad of different types of payer stakeholders. In addition to patient-reported outcomes, we also got some great insight into attitudes towards REMS as well as biosimilars, which I'll be presenting at a couple upcoming conferences next month in Washington and Baltimore. So the first question attempted to gauge the general familiarity with PRO, and as you can see here, most payers were familiar or somewhat familiar with patient-reported outcomes. The second question gauged where PRO data comes from, the product developer or an entity, another entity such as ARC or NIH. And as you can see here, most data is still originating from the product developer standpoint. What types of formats are most popular for communicating PRO studies? The clear winners here are AMCP dossier format as well as peer-reviewed journals. Surprisingly, it doesn't appear that product developers have really capitalized on HTA submissions used and already reviewed in the EU and the UK. And you can also see here ISPOR has some influence as well. Overwhelmingly, third parties are viewed as being credible, which is interesting since we learned just a couple of slides ago that payers are seeing PRO data coming from a seemingly non-credible source, the product developer. So it makes sense that current PRO patient-reported outcomes data are really not being used regularly as payers make coverage policies, as they don't view the majority of PRO data available with a high degree of credibility. A few respondents who had used PRO data in their coverage policy processes mentioned the correspondence to healthcare effectiveness, the healthcare effectiveness data and information set, as well as having used PRO in a comparative effectiveness review with Reclast and Xgeva. ARC studies were also mentioned as having been used in the past as a data source for patient-reported outcomes. So how likely are payers to use patient-reported outcomes to make coverage and reimbursement policy decisions in the future? It still appears that payers are reluctant to commit to future use of PROs, likely because of the lack of availability of credible studies. And I'd like to specifically reference the third statement on this slide. The issue is reliability. Since the PRO information is still being developed, the standards and guidelines for good PRO are not clear. I think overwhelming theme of this study is highlighted in the statement. The standards aren't clear. The data isn't yet viewed as credible. Until that happens, I think patient-reported outcomes will still remain very back of mind to payers. But however, and this is the big however, if CMS publicly leverages results of ARC studies to make coverage decisions, will private payers follow suit? And it appears that this is the case. Private payers will follow CMS lead. I don't think this is really a big surprise to any of us, as we all know how CMS tends to be the pack leader. And lastly, who are payers looking to for leadership in the area of patient-reported outcomes? Clearly, health economics and outcomes research consultants and CROs, contract research organizations, are the winners, followed closely by ISPOR. I do find it somewhat ironic that ARC scored the lowest in terms of leadership. I guess that's our federal government for us. And I apologize to anybody who might be here attending from ARC. So some key learnings from the 2012 Inventive Health Payer Survey. Payers are definitely familiar with patient-reported outcomes, but there's still a lot of room for improvement. We can certainly help to educate them on the value of patient-reported outcomes. As I mentioned earlier, the main theme of the payer study was that there's still a lack of credible evidence available currently, and the organizations viewed as being credible, namely CROs, HEOR experts, and ISPOR, need to really take the lead on developing standards and guidelines for patient-reported outcomes research. If CMS takes a lead on using PRO in coverage policies, then it's likely that private payers will follow suit in their evidence review process. As we've talked about how evidence ties into value, value then connects to coverage and reimbursement. I wanted to just very briefly mention a project that Campbell Alliance conducted last year on value and contracting within the US payer community and presented the results at a roundtable at AMCP last year. This slide sums up some of the key learnings from the research. We know that benefit designs are shifting rapidly, moving costs from the payer to both the manufacturer and the patient. Additional access hurdles are being put in place to restrict access to patients for which the technology is appropriate. True patient-centered value is a core shift of this, the core focus of this shift, as consumer-driven plans begin to place emphasis on personal responsibility for the patient's own health. Price increase caps are beginning to take shape as risk begins to shift from payer to manufacturer. Manufacturers will really need to factor in these outcomes goals into their clinical development programs in order to be prepared for how the product might act in the real-world setting. And we'll definitely talk with Steve a little bit more about that. Adherence and compliance programs, I've definitely heard over the past year or 2 years, are becoming valuable tools to influence patient behavior and ultimately positive outcomes to benefit the patient, to the payer, and the manufacturer. Ultimately, innovative contracts will be the motivation in this new decade of health for more intelligent product development programs. So once we've generated the patient-reported outcomes data, what do we do with it? What is the future of payer-industry relationships? I think it'll come in the form of innovative contracts. While innovative contracts have definitely been in existence in Europe for years, they still remain relatively obscure here in the US, although a couple examples exist. You might be familiar with the agreement between Cigna and Merck surrounding outcomes performance of its diabetes drug Januvia. So I want to talk just very briefly on the 3 different types of innovative contracts. The first being performance-based contracts, in which the amount of a rebate is tied to an outcome or a behavior. More risky is the risk share agreement, in which the manufacturer assumes some type of risk based on anticipated utilization, adverse events, performance, or some other type of factor. Less risky than the others is the traditional contract with a twist that can be based on something other than volume or market share, such as rewards for loyalty or escalating contracts. Some of you may have heard last year of the recent launch of Prime Therapeutics' care-centered contracting program. This program requires manufacturers to take risk for the cost of therapy or the cost of a medical intervention in the event that a product doesn't work as advertised. It even goes beyond outcomes to include requirements around cost of care, adherence, and patient education. This is the first U.S. payer to take a bold and aggressive look and move towards innovative contracting within our industry. So I would say watch for additional payers to take a step in this direction in the near future. So this is where the rubber meets the road. We've developed evidence. We've engaged in some type of contractual arrangement with the payer. How do we effectively communicate this evidence in a persuasive and compelling fashion? First, tell a simple and complete story that can be delivered within a finite time frame. I think this respects the limitations of time on a P&T committee, as well as a medical and pharmacy director. Second, be transparent. And last and most importantly, demonstrate credibility. We've talked a great deal about that over the past 20 minutes or so. This can be the most difficult to achieve due to differing perspectives on real-world studies, but showcase your best attempt by validating the study's design through external peers and use accepted methodology. The International Society for Pharmacoeconomics and Outcomes Research, or ISPOR, is really the go-to source right now for observational research methodologies. And if you can get a key opinion leader to buy in or a medical association to endorse your findings, it's even better. So some quick thoughts to close. We all hear the call for value and evidence, evidence to demonstrate value. We know that this call can be answered through intelligent evidence development programs. We need to continue to have dialogue with payers and federal agencies throughout our development programs. And lastly, regardless of the outcome of this year's elections or federal court decisions on healthcare reform, we know that the value and evidence train has definitely left the station. So I think we should just all make sure that we're on that train. Thanks for your time today, and looking forward to the remainder of the afternoon. I'd like to take just a moment to quickly introduce Steve Bloom. I know Chuck gave him a brief introduction. Steve is Vice President of Commercial Development, Business Development, and Government Affairs at Zyopharm Oncology. Is there anything that you don't do? Zyopharm Oncology is a biopharmaceutical company engaged in the development and commercialization of a diverse portfolio of small molecule cancer drugs, and currently focused on 3 clinical programs. Steve has a really diverse background prior to joining Zyopharm, both on the industry and the service sides, working at Parexel, IMS, Pharmetrics, and Lilly. Steve has worked in the areas of medical communications, health outcomes, data analytics, marketing, corporate affairs, sales leadership, and managed care. And please join me in welcoming Steve. So I'm going to take a moment to actually sit down very quickly with Steve. What we wanted to do is just kind of I've done this a number of times with Steve. He has some great insight, especially into the concept of integrating reimbursement and overall market access goals into the early phase of clinical development and even into a preclinical setting. So what I really wanted to do is just allow Steve some time to share with you what his organization's goals are, and really perhaps give you guys some advice. I'll let you have the chance to ask some questions to Steve. So before we begin, Steve, maybe you could give us just a basic understanding of Zyopharm, what disease areas you're targeting, and a little bit about your lead asset.
Thanks, Nathan. So, everybody hear me? So, we are a small biotechnology company. We're public, totally oncology focused, and we've been typically described as a development engine. In fact, our recent partnership with Intrexon would validate that, that premise. So we're 65 people, mainly R&D, regulatory, clinical operations, clinical, and our goal is to obviously, like every other small biotech company, see commercialization someday. How we get there through a partnership or on our own is something we're debating right now. When I got there 4 years ago, there was no commercial mindset. Some would argue there isn't much today, but it's only because we just haven't transitioned yet. But the evolution of the pipeline is now forcing us to do that. So as the calendar year turns, our lead asset, polyphosphamide, is a DNA alkylator. It's a small molecule. We've taken a life cycle management approach of niche to a broad label, if you will. So we'll start with soft tissue sarcoma. We're in a pivotal trial right now. Hopefully enrollment ends next month. We file an NDA a year from now. And the fun actually starts once the enrollment's completed, because we have to figure out what our commercial strategy is, business development. A lot pivots off of what we do in BD. Hence, it's okay that I have 3 hats, because they all need to be inextricably linked, because that's what drives our commercial strategy. Having said that, 4 years ago, the idea of value pricing or reimbursement was anathema to anybody at Zyopharm. And then as things evolved and healthcare reform evolved, and I got in the ear of the CEO on several occasions, convincing him that, you can build it, but they may not come. If we don't think about how to really value this asset and what kinds of what's our value proposition going forward, and we need to determine that. So early on in discussions, as the asset moved through phase 1 into phase 2, we started to think about, what could we do to find value in the program. And that's when we added the EQ5D to the pivotal trial and a quality of life instrument. And we worked with external consultants, a lot of what you were talking about. And here we are at the end, and we're beginning to think now, what is the output going to be once we start to analyze the QOL instrument, the EQ5D? What kinds of value proposition can we add to our pricing and reimbursement strategy discussions? So when we get to market, some people like to say flexibly, we're thinking flexible pricing. I like to think value pricing. But what do we charge, and how do we charge what we charge in this changing environment is very much top of mind for all of the executive team at Zyopharm. And so at the end of the day, we look at what some of the currently marketed drugs are costing per cycle, what the recently approved drugs are costing per cycle, and what can we sort of extract from the instruments that are embedded in the clinical trial to determine or drive our pricing strategy is very much top of mind right now.
Did you, prior to including the EQ5D in your study design, did you guys engage payers to really understand that they were looking for this information ahead of time? Yeah,
so my former life at Lilly, once you're a market researcher, you're always a market researcher. So one of my early roles at Lilly was to do market research in the CNS space. So when this came up, this very question came up, we went out and did one-on-one interviews with KOLs and payers. We had 2 distinct discussion guides, and we didn't lead the witness, so to speak, on the payer side. We hired a very experienced market research company, and what we were looking for was, what did the KOLs think? And we gave them sort of what we're calling the target product profile, and then we gave the target product profile to the payers. And we didn't lead the witness with any kind of pricing bands. We wanted to get a sense of where the hidden value sort of opportunities are should the phase 3 trial pan out the way we expected it. So the phase 3 trial was designed basically off of the phase 2 trial with some minor tweaks, but we felt like the phase 2 results and what the value proposition coming out of the phase 2 was, you could almost layer it over what we expected out of the phase 3, and so that's how I ran the market research. And we got some interesting feedback in the sarcoma space and the small cell lung cancer space, which we will begin a pivotal trial in small cell lung cancer middle of this year with first patient in June. And so we wanted to get a sense sort of ahead of time as to what the lung cancer KOLs thought and what the payers would think about our expected outcomes from the lung cancer trial. So all this is, again, it's something that's not endemic to Xyopharm when I got there, but realizing that, and there are several payer representatives in the audience, I mean, we have to convince you that this product is, and its value proposition is worth whatever we're going to charge. So that's the new paradigm going forward, and it includes not only the small molecule portfolio, but the synthetic biology portfolio that we're partnered with Intrexon on. We're going to have to, early on in phase 1, phase 2, think about, are these products reimbursable and at what cost?
Well, I apologize. I got the 5-minute card about 8 minutes ago from Chuck. So I would definitely recommend, if you had the chance to talk with Steve during the next upcoming break. He has a lot of really great ideas. I think a great case study of the right way to develop a clinical development program.